on roll. Good evening, everyone. Sorry we're getting a little bit late. There was a bit of confusion and technical difficulty today as oh, that's right. I didn't have my glasses on. I couldn't see which was the right number. That's probably what happened. I need cataract surgery like my sister over there. Hey, Andy, with your 2015. Well, I hope everyone's had a blessed week. There's so much going on, so much more since we talked last that's going on around the world and around our own communities. I just hope that you all are staying safe and have a peace of mind and an approach and outlook that is one of hope and faith and love and most importantly, compassion. Because these folk are confused. They don't know what they're doing, and they're trying their best. When I say folk, I'm not talking about us folk. I'm talking about the other folk. And they're just doing their best to try to learn, understand, and be comfortable. So I'm going to go ahead and say a quick word of prayer, then we'll get to the presentation and conversation tonight about COVID or whatever else you'd like to talk about. Bow your heads. Most kind, gracious Father, we thank you again for another wonderful, blessed day of health, of strength, of vitality, and of clear mind. We thank thee for everyone who has taken the time to gather on this call for edification, for sharing, and even disclosure if necessary, dear Lord. We ask that you would be with me as I try to share what you've given to me, that we may be able to help ourselves provide a more healthy life, choices, outlook, and share that with others. Be with us and keep us in Jesus' name I pray. Amen. Okay.
Amen. Let
me share my screen. I just have a few slides today, and then we can get right into a sort of a conversation if you want to have that, because there's a lot that we could talk about. So much, including opening the church back up, a lot of things. And so I'm happy to go in any direction you all would like to go in. So let me say first, this is number 8. This is the 8th week of us doing this. I'm sorry you lost my picture. You'll get it back soon. But this 8th week of us doing this, and things and trends over time seem subtle from week to week. But when you take that cross section in time and you compare what things were like in April, the beginning of April, just 2 months ago to now, things are actually quite different. Let me first just remind you all, it's hard to remember this because you see so many people walking around without masks. You see so many people walking around as if everything's back to normal. Not a new normal, back to the old normal. We see people just out and about. If you pass by a restaurant, you see people just in restaurants congregating at bars, around tables, no mask, no nothing. Just talking, eating, and drinking like everything is normal. And again, the challenge of this all is in this one slide where we know that this is a very different disease, as a reminder, than the flu, which has an incubation period of 1 to 2 days, and this has a mean incubation period of 7 to 10 days, meaning that you can be exposed and not know about it. And most of the people will even, 80 to 85% of the people won't have any symptoms or mild symptoms at best. So that means that you could be exposed, become contagious, have minimum or no symptoms, and spread this around. And again, the majority of people will do just fine. The challenge will be that they will spread it and continue to spread this amongst people until it hits somebody who is very vulnerable and susceptible for complications. And then as it spreads throughout our communities and risk people, the vulnerable people, again, people will actually come to the hospital, our hospitals will be overburdened, people will get unnecessarily exposed and sick and may even die. And that's the problem with this disease. We have no treatment. There is no vaccine on the horizon, okay? And I think it's very important for us to still be thinking about how we keep ourselves safe and how we keep others safe. So I just want to put that forward so that's right in the forefront of our brains. As far as I'm concerned, things have not changed. At our best guess, maybe of the population, we have somewhere around 11 or 12% of our population who may have been exposed. We don't have anywhere near the 60 or 70, maybe 80% of the people that we need to have herd immunity. And we don't know as well whether that immunity is going to be long lasting. So we are way out of the woods for this, and this normalizing mindset that people have. I do not want you all, my good people, my good Black people, to fall for the okey doke, okay, and just start taking things lightly. So having said that, what do our numbers look like? On April 6th, just 2 months ago, okay, 2 months and a week ago, we had 16,000 cases, okay, 16,000 cases and in the county of Los Angeles, and 385 deaths. 2 months later, we actually, have quadrupled the number of cases. And you can see the number of deaths is actually about 8 times that, okay? So significant changes. And if you look at the graphs at the bottom, and let me just get my little highlighter pencil out, so nice here. What you can see here is that we do sort of have this wave, if you will, of sort of how things increase, go up and down, then it sort of goes up and down again, and we get sort of new sort of plateaus, right? So if you were going to look at this, it might look like this. The next one might look like this, okay? And one can see, if you're just to draw what we call a regression line, that line is still going up, okay? So we know, and I know from my calls with the Department of Public Health, the number of new cases per day on average have still been going up. Now, we might argue that that may just be because we're testing more people. Maybe. But let's look at a hard fact that's very difficult to fake, if you will, or make an artifact of just sort of availability of tests. And that's the number of people who are dying from this. And so one thing we can say is that while there is a rapid increase in people dying, that is now sort of leveled off, and maybe it's slightly going down, but it's not going rapidly down. And so we know and we hope that most lung diseases that occur, that are lung infectious diseases, we know that as it's warmer, and warmer in a comfortable manner, meaning warmer enough for people to go outside and be about, but not too hot where they actually have to stay confined. So we've already seen in Texas and in Phoenix, Arizona, that the same numbers, when you start looking at deaths, actually have not leveled off quite a bit, or sort of slight decrease. And that's because they are not afforded the same benefits as we have in sunny Southern California, where right now it's outside, we're in the 70s, and if you're in Phoenix, it's over 100. And so weather in certain parts of the country will allow for people to spend more time outside. And if you're outside, there's a less risk of transmission. People are healthier, they're upright, they're expanding their lungs, less chance of a disease setting in, and that's a good thing. But there are many places in the country where this time of year is actually quite unseasonable, quite uncomfortable outside, and they may not get the same benefit. So we just have to wait. But this data tells me that we still have new cases, we still have new patients getting sick. We actually can tell you from the hospital perspective, if in fact we still have a large number of people in the hospital. So what you see on this graph in the light blue are people who are hospitalized but not in the ICU. And then what you see in the darker blue are people who are in the ICU. And plus or minus, over the last month solid, we've had between 500 and 550 people in the hospital, in ICUs across LA County. That has not really changed that much at all. We have actually seen that we have somewhere around 1,500 additional people to 1,600 people, additional people between mid-May and now. So for the last month, who are in the hospital, not in the ICU. And I can tell you again from my daily calls with UCLA, the Department of Health Services, and that includes hospitals like Cedars-Sinai, et cetera, we're seeing an increase in the number of people who are in the hospitals, even though that's not reflected in the ICU count, there are more and more people trickling up slowly who are coming to the ER who are sick. And we think that's because there have been people who've actually just been roughing it out at home. And now we have more and more people who are coming to the hospital. So all of this data is to say, we're not out of the woods. There's still plenty of new cases of people who are getting this disease, which means that there are plenty of people who are still spreading this disease in the community and in confined work areas. And let me just give you a quick example of this. In a hospital, you can imagine we're taking every precaution we can, right? We are wearing all the proper PPE, people are washing their hands. We test patients before they come into the hospital, before they're even allowed to be admitted to the hospital. And even with all of that, we have outbreaks even inside of the hospital amongst our workforce members, meaning doctors and nurses, as well as even patients in the same room. So my point is, we are doing everything. We're testing people, we're wearing masks, we're washing our hands, we're doing all that stuff in a hospital. And even in that setting, we have outbreaks. So this disease is still alive, thriving, and well. And it is still on you and on each and every one of us to take precautions to be safe. Not to be fearful, but to not relax and take things for granted. And so that's really my message for today. No matter what you hear, no matter what you read, remember that so much of what is actually coming across the news media is heavily biased by the economic and political agendas of folk in our society, of folk in influence and authority in our society. And this is really important. We've heard everything in polar opposite sort of facts reported on CNN and even in the paper. And in fact, this week, I believe yesterday, the World Health Organization came out and said, well, we're not even sure that, this asymptomatic spread is a big deal. I can tell you from personal experience working in the hospital that there is so much asymptomatic spread that goes from employee to employee, just in workrooms. So this idea that there's not asymptomatic spread or trying to play that down plays into the hands of the political and economic pressures without concern about people. Remember, the mantra for COVID-19 when it comes to the population is profit over people, not people over profit. So listen to things with that context. Is this a profit over people sort of statement? Or is this a people over profit statement? Okay? All right. So California's in the stage 2 of opening up. And again, I think the pressures for doing so over the last month are so strong that it's unlikely that we will go backwards and that they will do whatever they can to minimize this disease, including potentially not be as vigilant about the reporting of numbers. So I am very concerned about that. What I can tell you is that they can't hide the numbers from me because I know how many patients are in the hospital. And I know how many people are in my hospital and in Westwood. And so I can tell you from firsthand whether or not things are changing or not. And I will make sure to be transparent and honest with you all. But I am not sure that they will maintain the same transparency with the population because they are, really set on moving forward from stage 2 to stage 3 and just trying to recommend that people still remain physically distanced, still actually kind of adhere to some venue specific sort of guidelines and precautions, many of which are not being taken at all, with no enforcement whatsoever. So again, I would encourage you all to remain vigilant and safe yourself. Okay, with that, I am opening it up for whatever questions you all might have. And I'm going to switch screens real quick and stop my broadcast so I can see your beautiful faces. Okay, what questions might people have?
I got a question about testing.
Yeah.
Uh, our school about to have employees come back and phases starting in a couple of weeks. And one
Yep.
thing they're recommending is that everyone get tested before they come back.
Yeah.
Would that be effective or a waste of time?
Okay. There are two sorts of tests that are available, right? So there's the swab test,
Mhm.
nasopharyngeal swab test, and then there is a blood test. The blood tests are not officially approved by CDC because the blood tests do not accurately reflect disease state. Now, what do I mean by that? The blood tests that we have primarily available detect antibodies. Those antibodies can cross-react with other antibodies. So it may be that you have a positive test, but it's actually positive for another coronavirus and not COVID-19 or SARS-CoV-2. That's the specific name for it, right? So it may cross-react with others. That's number one. Number two, you could be positive, but you could be positive because you were previously exposed. And because you're previously exposed at some point and you have antibodies, it doesn't mean that those antibodies were completely protective now of a new exposure. We are not convinced in the medical community that you can develop true immunity that's long lasting, meaning that there are people we know, we've documented, who have antibodies to the disease who've gotten reinfected. Okay?
Wow.
So we know that. And that's just because this is a funky disease, okay? It's just a funky disease, like the common cold. I mean, think about it. You guys, everyone on this phone call has had a common cold. Everyone on this phone call has had a cold more than once, right? So if you were going to simply say, oh, I got a cold, I'm protected from having a cold ever again, well, that's not true. We all know that. And this is one of the cold viruses. So this should not be that surprising to us, okay? So the test for antibody doesn't say whether or not you are currently infected or not. It doesn't rule out that you're infected with or that you're previously exposed by SARS-CoV-2 or this COVID-19 virus. It doesn't say that because it could be a kind of cross-reactive antibodies to other related organisms. And number three, the antibody test only just tells you you've been exposed at some point to something that looks like this virus. So that's all it tells you. Now, so there's no reassurance there. That's why it's not recommended by the CDC, okay? Or the FDA properly. Now, what about the nasopharyngeal swab? Why do I hold this in my hand? Because there's an oral test, and there's a nasopharyngeal swab test. The oral test tends to be not as reliable in terms of sample. And so most people believe that the best sampling to rule out coronavirus and having active disease present or not is a nasopharyngeal swab. Let me make sure I demonstrate to you how this test is done.
Ooh.
Okay, this test,
Dr. Harrington, we love you. I don't know if you want to do that.
Well, I'm going to just simulate. I'm not going to actually do it.
Okay. I'm glad to hear that. Thank you.
Okay. But this is a swab. And you actually have to get the swab almost this far back for it to be a good sample. We call it a brain biopsy. Okay.
Thank you.
Affectionately. But it does need to actually be fairly deep. And a lot of the false negatives that we've seen have been sampling error. In other words, someone's getting this, right? The swab, and they're sort of jerking back, obviously, it's uncomfortable. All you have to do is go on to the website, the LA County Department of Public Health websites, and look at a testing site. And then once you get to a testing site, they have a video, or you can go to YouTube and look at a video on nasopharyngeal or just testing for COVID, okay? And they'll show you. This swab is like that long. Okay, this is Apple Pencil, it's long. And you have to have almost all of this disappear, okay, in your nostril for it to be. So I'm not saying that to say don't get tested if you have symptoms. If you have symptoms, get tested. okay? But if you don't have symptoms, the value of a test when you're asymptomatic is quite poor. If it is, let's just look at it this way. If you have very little or no symptoms, it may be negative for two reasons, right? It may be negative because it's too early in the course of disease for it to be detected. So then what are you going to do? You're going to get tested again?
No.
You can have two brain biopsies? No, right? That makes no sense, right? Or you can simply say, I have no symptoms, and getting tested only with the swab only tells you one thing. It only says, let's say you get a perfect sample, and it's an accurate sample. If you get an accurate, perfect sample today, and it comes back negative, what it means is today you're not infected. That's all it means. It doesn't mean that tomorrow you won't get infected, or that your exposure from 3 days ago won't give you symptoms tomorrow. So getting tested today when you have no symptoms only simply means you don't have an infection right now. That's it. And so when now passes, it's no longer valid. Okay? Hush boy. Andy, you saying hush boy to me?
No, I was saying that to Marky. I'm sorry.
Mm-hmm.
I'm sorry.
You guys have to worry about, let's see, when you do Zoom chat, you have to be careful in private Zoom chat that it stays private. Otherwise, everybody sees it. Anyway, I hope that makes sense to people about this, okay? Vina V says, I'm thinking my test sample may not be good. I didn't go that deep. Nurse said, feel for bone and stop. That's right. And if you were not bucking your head back out of discomfort, that was not a good sample. Period. I've seen it done. I've seen it done in person. I don't have the heart to do it on a conscious person. Okay, you'd have to have a little bit of malice in your heart to do it, because it's a deep specimen. Okay. All right. Other questions. If you're symptomatic, if you've got symptoms, you should
So
get tested.
going back to David's question, Darrell, as using even the nasal swab test for re-entry back into work, if that's what they were going to do. If you're not symptomatic, it's not going to be good.
So I apologize, Dave. I didn't answer your question directly. Let me answer it directly. There is no utility of value of screening people, quote unquote, with a test before coming back to school. In fact, like we're about to start 180 new residents and interns July 1. Every year we start 180 new people in our system. And around the country, we're having a conversation like, should we test them? What should you do? And the balance of people are not testing anybody, because what are you going to do with the information? If it's negative, what does that mean? Just an asymptomatic person. What does that mean? Andy, you look a little odd. What's the matter?
Because I was rubbing my eyes. I'm sorry. And I just had surgery yesterday.
Yeah, don't do that. You're going to rub those stitches off, okay?
Oh,
All right.
okay.
All right, you'll be okay. So it's very, very important to remember that a negative test in the asymptomatic group does not change your management, does not help. Does not help. And for the very few people you're gonna catch that you're gonna quarantine, for example, or isolate, it's not cost effective, because you're gonna test thousands and thousands and thousands of asymptomatic people to find just a few who have a positive test. And some of those people are going to be false positives, and many of them are going to be false negatives, meaning that they actually have the disease and you missed it because they won't allow you to do a brain biopsy. Okay?
Dr. Harrington, why, if the major attack of the virus is on the lungs, why can't we do tests for the lungs, or is it too late?
So that's a good question. It's a really, really good question. So you're absolutely right. On one of the presentations, I think last time or 2 weeks, or in the podcast 6, I went over sort of what we call the pathophysiology, how how the infection actually gets into your system and where it attaches, right? And we know that as it gets into your system, your airway, your sort of oral airway, it attaches to very specific cells and the receptors on specific cells in the back of your throat, as well as in your airway, including your lungs. And that's where it attaches and sort of does its work and replicates and all that. Well, you can imagine that in order to get a specimen in your lung, that's a pretty invasive procedure. And so what most people do, if they want sort of lung specimens, is that they give a sputum specimen. And the challenge with that is that, as you probably know, the variety of symptoms that people have includes just a fever with no cough, a dry cough, maybe muscle aches, a variety of things that don't include a productive cough with sputum. So getting sputum specimens, if you will, or getting lung specimens or tissue specimens non-invasively is actually fairly difficult and also unreliable for the many people who don't have lung symptoms as a primary symptom. So it's a really good question. It just becomes either, number one, invasive, too invasive to do, and number two, unreliable because so many people have non-lung symptoms. Okay, did that answer your question?
Yes, thank you.
Yeah. Okay. Other questions?
Well, I guess my question goes back to specifically Normandy, reopening Normandy, the conversation has started. What would you say would be the biggest risk factor? Because we have a smaller congregation and a large sanctuary. And if we did the testing and social distancing.
When you said testing, you mean a temperature, Andy, right? Because I'm not.
Yeah, the temperature.
Yeah. So I think that so two things. One is I think that the church and all churches should think really hard about opening and actually go back to ask the question, what problem are we trying to solve? Why is it that we are potentially rushing to reopen? I can't answer that on this call, but I think that church boards and organizations need to be honest about that. Just like a restaurant owner, just like anyone who has an organization or business or something like that, okay? Having said that, having a very honest conversation about that and making sure that at their foremost is the safety and well-being of your constituents, of the people that you're serving, right? And the people that are serving, then move forward. Okay, so let's just put that aside. Can it be done safely? Sure. Can it be done safely with science? No, we don't have any good science to tell us we can do it safely. We have our best guess that says we can do it safely. And what does that mean? That means physically distancing. That means controlling the way people come in and out of a sanctuary, right? And unnecessary contact and proper hygiene, etc., as well as ensuring that the people who are the most vulnerable and the most at risk don't come into the sanctuary. So that sounds discriminatory in some ways, but think about that. I won't call any names, but let's just say, there's a 88-year-old member, stalwart member that comes to Normandy every week, okay? And we reopen the church. If I was a responsible person running a church or a church organization, I would not allow the 88-year-old in the congregation, period, right? Because I would not want to have someone, let's just pick on Jouette, right, who's asymptomatic, who doesn't know she's got disease and is contagious, okay, come into the church.
Yeah, Doc, that group is not allowed in. They did bar
we work in
that
hospital, Derek?
age group.
Yeah,
No,
well,
the church guidelines say that age group cannot return.
Oh.
Yeah, well, what I'm saying is that I use that as an obvious example but I could extend that in some detail, because again, it goes back to what risks are we willing to take, and who is willing to take that risk, and what liability you would want to have. Now, there's some obvious cases, frail elderly people, that's obvious, but there are people 50 years old with hypertension and diabetes. What about that person? Okay. There are people who I told people on this call that one of the reasons why the US has some of the highest risks or the highest mortality rates in the world is because of our obesity rates. Okay. I told you guys that on this call. And so now what are you going to do for obesity? What level of obesity? So I have a young person who's 30 years old, 35 years old, but is 5'2" and 300 pounds. Okay, they don't have diabetes. What about that person, Derek? Right? So I'm telling you that people who are taking care of this disease, people who are really informed objectively about this disease and have the sole, singular frame of best interest of the congregation of participants, etc., should be do believe that this is the sort of situation like the NFL. Okay, I'm just going to tell you straight out, right? Where there is a little bit of bias in the same people who are trying to push for reopening. Okay, I'm telling you guys frank. So if you want to be really informed, really cautious, and really thoughtful about this, you've got to have a really thorough conversation. And I am not sure that the same organization who's planning for its own reopening is the best to inform on that. Okay, number one. Number two, I think that there are a lot of things that we can do to mitigate risk in the organization that is consistent with the CDC guidelines, controlling influx and efflux in and out of the sanctuary, controlling surface decontamination, mandating mask wearing while you're in the sanctuary, and a variety of other things that I think can mitigate that for what I would consider the low-risk congregants, because that should be the only people who should be coming to church, should be low-risk congregants. That's it. And I think we have to define non-low-risk congregants very intentionally and not just look at the obvious super high-risk people like the 88-year-old frail individual, but look at really seriously have discussions about other groups and other people, which I will tell you, when I look at, I've shown you guys this on these podcasts directly. I've showed you guys the distribution and breakdown of people who have died from COVID. I've shown you the distribution and breakdown of people who have actually been hospitalized from COVID. I've shown you that. And if you all remember that, well, only 25% or so were over 65, right? So I've shown you guys that data. So we have like hard data on that. And if we make informed decisions about who we think is really at risk, not just super high risk, but just higher risk than, I'm just going to throw myself out there, higher risk than me, okay? And I'm not super duper low risk like Marky, but we have to establish what baseline risk we are going to accept in our congregates, and then establish mitigation for that group. And then everybody else, we absolutely do not take the risk for their sake, not just to avoid liability for the Adventist Church or Normandy, but to keep our sisters and brothers safe, okay?
And we also have to look at the time in which we're all together in one place.
Yeah.
Just sitting there. We have to look at that, because that's crucial.
Absolutely. There's no question. We talked about this early, in our podcast series, if you will, that this notion that you walk by somebody and you get it, it's not going to happen. But, you know, you sit down and have a 2-hour conversation with somebody and they're sick, yeah, you know, it's a different story, right? And that includes people who are wearing masks. Okay? Because people aren't all wearing, we talked about this. There's these cloth masks, unless you have one made by Hope. That's just another plug for Hope. But even Hope's masks aren't perfect. So, you know, your cloth mask, you're sitting across and you're, you know, talking to somebody. And just think about this. Just think about this. You're, two people have a cloth mask and they're talking. And they might even be 4 to 6 feet apart. Okay, let's just leave it at that, right? But they have cloth masks on. One is symptomatic. One is very symptomatic. I mean, not symptomatic, but contagious. And they are spewing out as they talk, or maybe even have an occasional sneeze or cough, okay, which is going to occur through their mask. And they may tuck their arm. They may do a variety of things. That gets on a pew or unmovable surface like a pew, okay, where people are touching. It's been disinfected before the service, but now the service is going on, okay? And you're talking with mask on. And so this droplet spreading disease now gets on the pew. And someone inadvertently touches the pew, because we have like behavioral stuff, brushing against things and rubbing or holding on. I hold on to get up, etc. And people, just like Andy's touching her eyes, and she just had surgery. She knows better than to be rubbing her eyes, and she just had surgery. So think about this. We have so much habit in touching our face, rubbing our eyes, and all this sort of stuff. I can't tell you how many people I see rubbing their eyes or, you know, touching their face, even though they know we've been preaching, you know, hand hygiene, et cetera, et cetera. So that only needs to happen one time, okay? And so I am not saying we should not open the church. I'm not saying that, but I am simply saying that the risk by just excluding a couple of groups, high-risk groups, doesn't go way down. And, you know, as Sister Elder said, you know, we don't run 30-minute services. You know, our services, even online, are long. So, you know, if we actually end up with, you know, our typical hour-and-a-half, 2-hour service, and you got people who are amongst each other, even physically distanced to some degree, if you take the physical distancing measures that you really want to take, it defeats the purpose of opening up, because you will only be able to fit so many people in the church, okay? And so it may not be a case. Sometimes on the Sabbath we have very small numbers anyway. So then you just have to really spread people out. But it's just something to think about. And on balance, I think we have to think about why we're sort of doing that versus sort of the risk we're taking. And I will tell you, in the education space, you know, we have transitioned almost all. We had true dependency on in-person lectures, okay? I mean, I pride myself in being in front of a group in a lectern and talking the gospel of medicine, okay? And teaching people, okay? That's what everyone has done for decades. For the last 3 months, Zoom, baby, okay? And I've had some extremely impressive interactions that forces me to be much more creative. It forces me to engage people in a different way. But we will never go back. Like, there's a small role for in-person gatherings and teaching and didactics now, but 85 to 90% of what we were doing in person before, boom, it's all changed. And we're not going back, okay? And so, and people, when we do our surveys and we get feedback, the only problem that we have is when people refuse to be adaptive, flexible, and innovative. If the people presenting are willing to be flexible, adaptive, and innovative, it's amazing what you can do in sort of presentations and interacting and engaging. So I would just say, not that this is something I think that I would like to do in perpetuity, but there are things that we can do to make the intermediate phase, the transition phase, even more engaged, more impactful, if we're willing to think about it's actually extra work, more planning. But if we're really willing to think about that, particularly if we consider the alternative, and if the alternatives are still with some significant risk, I would just urge us to think about that. Okay.
We are in the process of trying to make sure that everything is safe before we do open. And so I do have something submitted that maybe you can look at, but also I think that okay, let me be careful. Anyway, for me, I really miss church. And so I want to do everything to make it safe, but I also want to move forward on making sure that we're going that direction. Because otherwise, I don't know, I just think, personally, I'm just concerned that I think some of our pastors have been on vacation. I need them to come off vacation. We don't have a pastor. I don't know when we're going to get one, but that's a prayer point as well.
Yeah, I'm probably not the right person to even comment on that, Pam. I will say that I know there's so much value with, creating intimacy and contact between, one another in groups, both large and small. You cannot replace that. The human contact is completely irreplaceable. I completely see that and agree with that. And our church family, for some of us, is a main source of that love and affection that we get. And so I think it is so important, to keep that in the balance of all this. So it's notwithstanding that and acknowledging that I am making my comments, because I agree it's so important. I miss it in so many ways as well. But I do think that we do have to think about this, and we have to plan about this. And I don't know that we can simply trust, and I'm saying this purposely, I don't know that we can simply trust our leadership. And when I say leadership, I'm not talking about our church leadership. I'm talking about leadership at the department, state, government level, with regard to their very motivated push economically and politically to get things going again. And so I think we have to be very cautious as we think about how we move forward. That's all, because it is with some real risk as this disease continues. I just showed you tonight, this disease is continuing in our community. Remember, the people who get admitted to the hospital is just the tip of the spear, right? The shaft of the spear are the people who are infected asymptomatically in the community. The tip of the spear are the people who come to the emergency room who need to, be admitted to the hospital. So we know that the disease is still spreading in the community. We know that for a fact, right? So it's because of that I encourage us to be very deliberate, thoughtful. And I'm not saying that Pam and the rest of you all are not being that way, but as deliberate and intentional and thoughtful as we can be about trying to plan strategies to minimize risk, whatever risk we are left with, that should still be balanced with what is the benefit, right? And be very honest about that. That's all. That's all I'm saying. And I hope that you all don't take it, as me being, the Scrooge or discouraging.
Not at all.
Just want to provide, that sort of sobering piece of that. Someone just wrote something in the chat, two things in the chat. First, let me respond to Marcus. Even though it was private, Marcus, I'm going to still respond. So all these protests, that have been going on outside, should we expect a huge surge from that? I don't know, but I don't think so. Getting and spreading the disease outside, even in close proximity, has been difficult to prove, to be quite frank, unless you're actually around someone who is quite symptomatic, like very, very symptomatic, febrile, coughing up on all this other stuff. Otherwise, even with someone mild symptomatic, it's very difficult to pass this disease around, if you will. Okay, it's very, very difficult. So outdoors and the public protests, etc., probably won't really add to a surge. It's probably really the bigger risk with organizations and businesses opening up and maybe not taking the right precautions, as well as what's happening with people as they translate what's happening in the environment and society back to their personal behavior and precautions, right? So I look at people just on my block. I'm in my office right now. I've been sitting in my office right now, just looking outside, still a beautiful evening. A month ago, everyone passing by my window had masks on. People would go off the sidewalk into the streets to avoid passing somebody. Okay, that was a month ago. Now, the exception to people have masks on. Okay, and everyone speaks, and it's very civil, but no one's going off the sidewalk and all that. People have actually changed their mindset about this disease. They have relaxed about this disease. And that relaxation carries over to our behaviors in our homes, in our interactions with other people, even our loved ones who are coming over and visiting, Jackie, Andy, or whatever, right? And so it all relaxes. And in congregation, and in summation, if you will, the relaxing of that attitude and those behaviors add up to significant increased risk for the individual. Okay? So that's what I'm worried about. I'm not so much worried about outside in the protests. I'm worried about all the precautions that people were taking, where they're taking real responsibility for and being extremely vigilant, that actually relaxes and goes away. And then in our workplace, in our home place, in our interactions and with the other people, et cetera, et cetera. I was at home today working from home. There was a car accident on the street. I ran out to make sure that people were okay, the car accidents. And as I was there, I identified myself and started talking to people and looking at the two drivers who were sick and examining them. The crowd that amassed right around that, there was one person out of like 20 who had a mask on. One person out of 20. And they were all tightly together, right? Many of which who were strangers, okay? So what I'm getting at is that it's the mindset that's changed, and all the accompanying behaviors and risk are what I'm worried about. So I'm not worried about outdoors so much at all. All right, there's another question or comment. Great question. Janice wrote, New Zealand is now COVID-free. Well, sort of. Can I comment on that? So New Zealand is relatively COVID-free. They have not tested every single person, but we believe that New Zealand, for the most part, is COVID-free. Now, let's ask the question, why are they virtually COVID-free? It's because they virtually had no one who had COVID in the first place, okay? And why is that? Because the equivalent of Donald Trump, who's a woman, okay, in New Zealand, as soon as she got the first whiff of this, she locked down New Zealand. She locked it down. And she kept it locked down. And she kept it locked down, and their public health system went to work on a finite population with a very few cases that they could identify, test and identify, and quarantine. And they were relentless in their public health efforts with a much smaller population, a much confined population, and very few cases to track down in the first place. So that's why New Zealand got a hold of this. Very aggressive at shutting down their borders and transportation in and out of the two islands. Extremely aggressive, extremely early on, and relentless with their public health department in tracking down cases and quarantining. That's why they were successful. If you look at New York, very late to shutting down. By the time they shut down, so many cases that the public health department couldn't even keep up with it. okay? Out of control. Same thing with Los Angeles, Department of Public Health. Not as bad as New York, but our public health department can't keep up with all the cases. We can't. We don't even have enough testing to test everybody, okay? So New Zealand, testing people like crazy. There are very few people who are symptomatic, identified those people, quarantine those individuals, and shut down the influx of people coming and going at a very, very early point. And you can do that when you have a relatively self-contained economy. So, you know, their economy is tourism based, but they also have agriculture and a variety of other things. And they were hurt based on tourism like every other place, but their economy isn't so big that it would crumble, okay? So they were able to shut down, survive, self-sustain, and control the population. That's easier to do when you have a fraction of the population of the United States, okay? But they, you know, kudos to their leadership because they made hard and important decisions very early on. And other small, you know, countries, if you will, didn't do that. So I'm not taking anything away from the leadership. They were, you know, quite progressive in that regard. Good question. Any other questions?
I got a question about Catalina Island. I was looking
Hey,
at the
before we
web-
do that, wait. Before we do that, Vina V said church outdoors, bang, bang. Now you're talking. You want to actually have church and just do it right and have no one have any risk or minimum risk? You have church outdoors, okay? You could have the same number of people or more that you could in the sanctuary, okay? Outdoors, on that lawn, and the passerbyers would benefit from that. We'd be automatically part of the community, okay? So you're talking about a genius idea? There you go, Vina, right there. Church outdoors, amen. Done. Okay, I'm sorry about that. I just wanted to acknowledge that. Go ahead, Catalina Island.
Yeah, I was on the website. They have the same shutdown restriction as the rest of the state does. And I was wondering, are they actually doing it or they're having a good time out there while the rest of us suffer?
You know, that's a good question, Dave. I just don't know. I'm not familiar enough with Catalina's data to answer that. I could look some of that up in a public health site right now to see just how good or bad things are going, but I'm just not familiar with that to make a, you know, educated comment. But again, you know, Catalina shut down visitors to the island. There's some essential workers that live on the mainland that go out to, you know, Catalina. But they have, again, a small population of Avalon, right? It's not like a super large population. But I don't know enough about what's happened there. I'm gonna look up something right now to see if I could find something.
Yeah, Doc, and while you're looking that up, maybe you can give the same kind of quick response that you did to Vina's comment, which I would agree with her, but if we're going to be back at that building, we're going to have to follow all of these guidelines that were put forth by the CDC and the conference, et cetera.
Yeah.
So we should definitely take our time and either get away from the building or just extremely pump the brakes on trying to get back in that sanctuary. And with that said, my question, which I think you already addressed, is there truly is, one of the things that was said is to take temperatures before people come into the sanctuary. I mean, what's the point? Is there any value in doing that? Is that going to give us any worthwhile data?
Well, sort of. I mean, but no. So it will catch the people it catches, but 56% of people at most have a fever. So, you know, that means half the people who are infected and are contagious don't have a fever. So it's sort of like, okay, you take a temperature and someone has temperature. Okay, send that person out. You take a temperature, that person doesn't have a temperature. Send that person in. You just sent one person home who has COVID, and you just admitted another person to the sanctuary that has COVID. You get what I'm saying? So checking temperatures by them, you know, by itself is not a reliable way to screen people. the best way to screen people or self-screen people turns out to be a more thorough questionnaire of a lot of other symptoms beside temperature, right? Yeah, and Vina talked about people taking Tylenol and everything else to mask fever, not intentionally, but just to feel better. And so fever is not reliable, okay? That's the point. Fever by itself is not reliable. And usually when people do that, if you're going to do that smartly, you can't rely on screening, fever screening alone. You have to rely on symptomatic screening, which is actually much more cumbersome, requires people to answer a series of questions before you let them by, right? And again, you're hoping that people are going to be truthful and honest, but someone doesn't have to be, right? So there's really no great way to assure yourselves that someone isn't walking into a sanctuary or walking into your proximity in the public domain that is not contagious or not infected. Pulse ox is not really reliable either, Andy, because again, that's just people with severe lung enough symptoms that it would actually cause a decrease in their gas exchange. And so even pulse ox won't do it for the majority of people. So there are no really good ways except for what they call a symptom screen. And a symptom screen only requires people not to be liars. And if they answer, no to everything, the chances are fairly low that they have, any real disease. But there's still a risk of people who are asymptomatic spreading the disease. I mean, they know everything, but they still can spread the disease. It's a lower risk, but it's real, okay? The problem with the, sort of people coming in is that most people are looking at, as you implied, Derek, hey, I don't have a fever, I don't have a cough, I feel pretty good. Oh, I'm sure that aching I have is because I did extra push-ups yesterday, or, that headache I have and little sniffles is just hay fever, Andy, and that's it, right? So I think that's what ends up happening with the mild symptoms is that they get dismissed as something else and people move forward with the sort of reassurance and non-disclosure that they actually otherwise feel fine. I hope that answered the question.
Yeah, I just didn't want us thinking just because we're shooting people in the forehead, taking temperatures, that we're doing something effective.
Yeah, no, it is not reliably effective to assure yourself, the individual being tested, or those around them that they are not infected or contagious. Okay. Other questions? I'm just looking up stats here. Yeah, there is no question that there are some counties and places that have so few, so few numbers. You go to Alpine County, Sierra County, virtually no one, right? But that's because it's an outdoor environment and they've got 10 people in the whole, the whole city, right? And they all live, on, 20-acre or 100-acre ranches, right? And so this is a disease of proximity. Let's just make no ifs, ands, or buts about that. One of the reasons why New York had such a hard time is because people live on top of each other. That's one of the reasons why Chicago had a hard time. One of the reasons why, our community, the Black and brown community, was affected so much by this is because they're the people who are living on top of each other, right? And so this is a disease of proximity. Make no, particularly in confined spaces, make no mistake about that. Okay, anything else? I'm not finding what I want related to Catalina.
just curious if you found anything. My mom's sometimes on the call. She's in Santa Barbara County. Have you heard or seen anything particular with regards to Santa Barbara County?
No, I mean, I have access to that data. I haven't looked at it specifically. That's something that I could look at pretty quickly, but I can tell you that Santa Barbara is obviously doing much better than LA County, just because of the geography of Santa Barbara County and the population. Most places that are spread out, most places that are largely still temperate in terms of their environment, which allows people to be outside, and they don't have such congregate housing, and the economic distribution of the population is much more horizontal as opposed to extreme. Those areas are doing extremely well relative to like truly urban inner cities. And so I'm sure, just like so many of the counties, the best place to get information if you're living in a place like Santa Barbara is to go to the Department of Public Health website for Santa Barbara County. All the public health websites are required to publish their updated statistics. And the most important thing to look at is not just the absolute number of cases that they have in the county or in the area, but right now, 3 months into this, what you want to know is what's the trend of cases, and particularly the trend of people being hospitalized or dying, because those are not artificially inflated because of the availability of testing. So if in Santa Barbara County, for example, the number of people in a hospital is going down, that tells you that something's really happening importantly and positively in the community. If the number of people who are dying is going rapidly down, that means that, again, either one of two things: the number of people in the community who are infected and are spreading the disease is going down, or the number of people who are susceptible, who are at risk of dying, are just all dead, okay? And so as a disease that could kill people, and the susceptible people sweeps through a community, and those people get it and die, the fatality rate will go down, just because the susceptible number of people who can have the complication goes down as well. I hate to be morbid about that, but that's just how that sort of data works. But that's what I would do. I would go to the public health site and look at the published data, and it'll tell you whether things are getting better or getting worse. But I would imagine Santa Barbara's doing, actually quite good. And I'm looking.
Also, just a quick comment. I've been to, I think, 3 drive-by events, none of which truly remained drive-by because of the desire for people to socialize and love on each other. It just didn't happen. So I have little faith that if, especially the first couple of times that something like a church would be open, that people would really break their necks to adhere to the guidelines. It's very difficult to do. The saving grace was that the drive-bys were outside.
Yeah, and the challenge again is like there's no reinforcement of it, Derek, because people are in their environments, in their communities, in their homes, have already changed their attitude towards this. And so I think that's the challenge. Now you expect them to come to church and all of a sudden be compliant with all this stuff? No, it's not going to happen. And what are you going to do? Go around policing everybody and every interaction they're having? No. 6 feet away. No. Put that mask over your nose. I mean, is that what we're going to do? Right. So I think that's a really good point. I did just find the Santa Barbara data, relatively speaking to LA County, it's like a desert of cases. Like there are very few cases. So in Santa Barbara, and remember, LA County, there's like 65,000 cases and 2,700 people have died. In Santa Barbara County, there's 1,700 cases total, 1,700 compared to 65,000. And there are only 11 people who have been listed as dead because of coronavirus. So I would say that Santa Barbara is a pretty nice place to go vacation.
Sounds like a nice place to have church too.
Yeah, we made one just go ahead, and it's 100 miles. 100 miles, and it's a quick little trip. But Santa Barbara is doing quite well. And again, like Monterey County and a lot of other places which are sort of horizontal in terms of the density of the population and spread out with a really nice climate. Those are all things that portend a really good outcome for a place like that. All right, let's see. I think I have a couple more questions on chat. We talked about that already, pulse ox, etc. Oh, Tylenol, we got everything. I've got it all. All right. Well, anything else? Normandites and others. Okay, well, thank you all very, yep.
Confirmation. You said the people who are asymptomatic are not really passing this because of, okay, so my question is this. To spread the disease, you have to cough, sneeze, or something like that, right?
No.
Okay,
So I did not say that people who are asymptomatic can't spread the disease. Absolutely not. World Health Organization put out a statement that they're not sure that asymptomatic people are really that effective spreaders. I would not listen to that, only because I think that statement, they've been silent. All of a sudden they make a statement like that when everyone's opening up seems a little suspicious for me. I can tell you that asymptomatic spreads absolutely happens. I've seen it. We have 2 outbreaks in our hospital among staff that spread it from the break rooms, okay? So there's no question that asymptomatic spreading happens. You don't have to cough for that to happen. You can shed the virus. And then you just simply shed the virus, and that virus shedding means that it can actually be projected in speech, conversation, sneeze. You'll be surprised how many times you touch your mouth, in about your mouth. There was a really nice experiment. You remember, maybe next time I'll try to show you all this. It's actually, I thought was on social media. They showed how quickly something could spread at a table. And it was something that, there are 2 experiments. One where there was something that was just put on the surface, and that was it. And the other one was something that was put like a breath thing. So like people took like basically like a Banaka blast. And so now only way that it can be spread is by talking, right? And they had like this neon infrared sort of thing. And for the one where they actually just put something on the table, you saw over time lapse during that same dinner with 5 or 6 people around the table, almost every single person had it on them, okay? Which was amazing. Like, it literally was being spread because people were touching things and sharing or handing salt and pepper or, a variety of things. It was amazing. And then when they showed the Banaka one, what you saw is you couldn't see obviously real time the particles going out from somebody, but you could literally see on people's hands, on people's outside of their mouth and face, on people's clothes, all over the table, okay? So this notion that, and people weren't sneezing or coughing, this notion that you have to be coughing or sneezing in order to spread a germ is not true. It is droplet spread, and we have droplet spread just in talking. And the spread, remember, goes like this. It just sort of goes immediately down. So if you're in short proximity, it's going to go onto a surface or what have you. That's just physics. And handling or touching, and again, as Derek sort of implied, removing all the vigilance and caretaking that we put in place. And now people are careless, they're not using hand hygiene, et cetera, you spread the disease, okay? So It's not that hard. And I think when you read and you see things, Venus said it was shown on CNN. I think the one that was shown on CNN was the one about the physical, like the hands are being placed on the surface. I think that's one I think I saw that on CNN too. But there's one about an aerosolized into your mouth. I will tell you that there's lots of, just like China. Let's remember, Chinese folk aren't that different from Americans. Okay, everybody wants, a good reputation, the ego stroked, and to make some money. Everybody. Okay, so China stopped reporting their data months ago. Just stop reporting it. Period. Okay. Is it possible? Is it possible that California, New York, or someplace in America who's motivated to get the economy going, who wants to actually get people back out, spending money and forgetting about this disease and knowing that the majority of people are going to be just fine and that only the vulnerable people are going to get sick, is it possible that they might actually change the rhetoric, change the reporting? That's not conspiracy. That's just, we've already observed it. It's already happened. So I completely agree, V, that this is something that we have to be very careful about sort of buying into this. And as long as we have people getting admitted to a hospital week after week with coronavirus, as long as we have people dying of this week after week with coronavirus, it's still a disease that's pervasive, that's walking around, talking around, that is at risk for you and me, whether we get sick or not, or pass it to someone who gets sick. So we still have to, as far as I'm concerned, have the same attitude. Now, I do think that there's some things that we've done that have been overboard that we can relax on a little bit, like I can't go running, or I can't bicycle without a mask, or, I mean, some of that stuff is a little bizarre and ridiculous anyway. But I think the other things, particularly as it relates to congregate settings, prolonged exposures in congregate settings, particularly enclosed, those are real things. And I would recommend, and I will continue to be vigilant in that regard.
Thank you for, and also I still need to review what we said, but thank you very, very much.
Yeah, so just send that to me and I'll be happy to look at that. Well, again, thank you everybody for taking the extra time. Last thing I want to do is, make anyone, again, sort of anxious, afraid, nervous. That's not it at all. This is about knowledge is power. When you have this sort of power, you can actually be in charge and in control, as opposed to be the victim of someone else's manipulation and control. And so that's my intention. I think everyone on this call, I would urge you all to share what you've learned. If you've learned anything that's useful to other people, empower people to stay vigilant. They don't have to be hermits. They don't actually have to walk around anxious and terrified, but they still need to remain vigilant and take care of themselves and protect themselves and those immediately around them themselves. So thank you guys very, very, very much for everything. And again, for participating in the great questions. And I'll say a quick word of prayer and let you all get on to the rest of your evening. Okay? Bow your heads. Gracious Heavenly Father, we thank you again for the time you've allowed us to spend together, to share, to learn, and to be curious and sometimes provocative. We thank you for all of that. We ask now that you continue to be with each one of us here that's represented and the families, and for those who cannot be participant on this call. Guide and protect us. Keep your safe and watchful arms around each and every one of us. Keep us wise and intentional in our decision-making and in our words. Let us be a witness of truth, a witness of hope, and all that surrounds our biggest calling, which is that of love and compassion. Be with us until we meet again. In Jesus' name I pray. Amen.
Amen.
All right.
Amen.
Amen.